Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
And good morning, everyone. How are you? Joe Basha here, your host of PerfWeb. I would like to welcome you to PerfWeb 38, Day 2. Today we're going to be talking about ECMO cannulation strategies and selection of cannulas, and also talking about hemodynamic monitoring. And with me today, I'll introduce, of course, John again. But let me get to the housekeeping notes that I have to do. Our sponsors, please make sure you visit their site. I've said it every show. I'll say it probably for every show moving forward from here. We really appreciate them. We really need them. And it really helps if they know you are watching our program and value the work that we're doing here. And of course, we appreciate you as the audience. But to make the whole system work, we need you, and we also need them. So it really helps quite a bit. Social media, make sure that you like, follow, share on Facebook, the Twitter, and the LinkedIn, and then also give us the thumbs up, subscribe to our YouTube channel, and click the little bell for notifications for our YouTube. We're growing in subscribership, and I think I said it yesterday, we are now the #1 subscribed to Perfusion channel on YouTube. I'm very proud of that and excited about it. And again, I owe it all to you guys who watch our show and subscribe, so thank you. Check out our websites, perfweb.us, which is perfweb.us is really the schedule of the live events that are upcoming. Perfusioneducation.com is our library of where you can go in. You have a free account that you can set up, and you can pay for CEUs. That's the only place where you pay for anything. Everything else is, of course, free to share our knowledge and share information with everyone, which I think is a fundamental responsibility, but we can discuss that another day. Nevertheless, it's our library where you can have you have your own folder. You can purchase CEUs. You can get all of your ABCP required CEU from one source, and especially now with what's going on with the coronavirus pandemic and really disaster, you're able to, because all the meetings got canceled, you're able to get all your CEUs in one place and be compliant with your board, both the American board and also your state license if you're in a state that also has that dual kind of certification process. So go to our sites, check them out, look around. If you have any questions, you're always welcome to call me or shoot me an email, and we certainly will respond quickly to that. Our call-in number is going to be right there, 832-239-5358. When you see that symbol, we're not going to leave them open all night because it's a little different format. There's actually going to be a lecture, or all morning, I'm sorry. But as soon as the lecture is over, we'll turn that on. And when you see that notification, you can call in and make any comments or whatever it may be. Now, something that I had forgotten to do yesterday at the beginning of the program, I did it at the break, was to talk about this site. This is a friend of mine. He does compliance learning. His company is Compliance Learning Solutions, and it's with an S at the end, so you got to remember that. This is what their website looks like. And they are offering for companies, and it could be any company. It doesn't have to be a medical industry. So if you have a side business, or your spouse does, or your family member does, or you're a small perfusion organization that is doing, has contracts, and you need to get your office staff compliant, and even your clinical staff compliant with COVID-19 best practices by CDC and OSHA guidelines, I highly recommend you go here. And David, if you could you click on, let's first show their library, because they have a whole bunch of different stuff. I mean, so this is kind of what their company does, and they have a lot of interesting things. HIPAA, of course, that's very exciting. Bloodborne pathogens. They have cultural diversity. So a lot of things that companies need. So if you're needing that kind of a resource, I highly recommend this. It's high quality stuff, and that's what I like about it. And you can monitor people's progress. They have a very interesting system. They have a quick video, because this course is free. And so if you need to get your folks certified in COVID-19 best practices for how to avoid catching it or transmitting it and keeping your workspace healthy, and also reduce your risk, mitigate your legal exposure, if you will, to not having your staff following these guidelines, this is a great resource, and it's completely free. So I think that's very important. You want to go ahead and play that video?
COVID-19 employee training. Protect yourself, coworkers, and customers. Clean your hands with an alcohol-based hand rub or wash them with soap and water. Maintain at least 6 feet distance between yourself and anyone who you come in contact with. Employees should wear a face mask when working in public. Clean and disinfect frequently touched surfaces daily. Ask your employer if it's possible to work from home. If you have a chronic medical condition, keep your usual medical appointments, follow CDC and OSHA guidelines, and follow state and local guidelines. Scientists from around the world are working on a vaccine for COVID-19.
Okay, thank you. So yeah, it's an excellent resource, and I highly recommend you check their site out. And don't forget, like I said, make sure it's Compliance Learning Solutions with an S, because there is one out there that doesn't have the S, and you don't want to go to the wrong place. This is a real high quality outfit. Okay, so let's go ahead and jump right into my slides if I can. As I said, we have, and John Ingram, I forgot. Oh, John, man. I tell you what, John, I'm wore out, John. I'm wearing out. I can't remember that you're on the show. So John Ingram, a stalwart of the Perf Web series, and somebody that if it wasn't for him, I really don't know what I would be doing right now. And he's gracious again to be coming back with us from Orlando, Florida. And you're at work right now, so we do understand if you get called or interrupted, you'll be back. So everybody do realize that. But I'm going to go ahead and start my lecture, John, and get that done. And hopefully you'll have some good comments to make about the presentation itself and my thoughts on it, okay? So I'd like to start this conversation out with just this really neat rotating diagram of the cardiovascular system, cardiovascular and pulmonary. The lungs are a little bit, I think, transparent in this case, but it gives you an appreciation for how simple but complex the system is. But remember, it is a closed system, and what you do anywhere in that system is going to affect things somewhere else in the system. And so you have to remember and respect that. But it's also what you do to really figure out, what am I trying to accomplish? What do I need to do? And I've shown this slide many times, and I think that it is a very good slide that, there you go, that shows what you should do. So I'm just going to start on the right side for the sake of myself, just a little easier for me to look at it. And you can see in the top right area, refractory hypercarbia. So you have a patient who's retaining CO2, can't blow their CO2 off. And then you just basically follow the lines. Do they or do they not have hypoxemia? If they don't have hypoxemia, staying with the right side theme first, then basically low flow veno-venous ECMO will be fine for that patient, because that's a lot easier to deal with in terms of clearing CO2. But if they do have hypoxemia, then you're just going to do standard veno-venous ECMO. And the hypoxemia doesn't have to be as severe as you would expect, like if you were doing it for true pulmonary failure and complete lack of ability to oxygenate the patient. But this could simply be somebody that, say, had a PaO2, FiO2, an FiO2 PaO2 ratio of, I don't know, let's say 200 maybe, just borderline, but their PCO2 was 80, 90, this you would do the low flow. But if it's somebody who is worse than that, then obviously you're just going to do straightforward ECMO. If they have refractory hypoxemia and a Murray lung score of 3 to 4, then you go down and you choose, are they or are they not in cardiogenic shock or vasodilatory shock? If they are in, if they do not have cardiogenic shock or vasodilatory shock, then you can see immediately you just go to veno-venous ECMO. If they are in cardiogenic shock, then you have to ask yourself a couple of other questions. Is it due to hypoxemia? Because hypoxemia will itself cause you to go into cardiac failure. Or are there any, is there any other reason? They had an MI. They have myocarditis. Something else going on with that patient. They have an acute valve failure. I mean, anything really you can think of. Then if it is due to hypoxemia, then you're actually going to go to veno-venous ECMO, because that really is the appropriate thing to do. Once you get them oxygenated, you'll see the heart come back. And I have seen this happen many times in my career now. But it's you've got to be sure, because if they truly do need mechanical circulatory support, which would be on the left side, any other heart failure cause, then you do need veno-arterial or veno-arteriovenous, so combined VA and VV. So it would be V-AV is how you would set something like that up. But you could also have just dual circuits, one VV and one VA. That's possible too. And we'll talk a little bit more about all of these options that exist. And hey, John, if you see something or hear something that you want to elaborate on, could you just jump in?
Sure, absolutely.
Yeah, if there's something that I say that you want to expand on or clarify, don't hesitate to just step in and say, hey, let me ask you something about that. So the classic indications of mechanical assistance are, there's 4 types of indications. There's a bridge to recovery. You basically have, let's say, post-cardiotomy syndrome. You can't get the patient weaned off pump. You put them on ECMO, or you have somebody that comes in with influenza or influenza B, and they go have ARDS. and you put them on ECMO, and do you think they're going to recover? That's bridge to recovery. A bridge to a bridge is basically that you are keeping the patient alive in order to give you time to get the patient to either a short or longer term VAD. So you're bridging them to another device. There's bridge to transplantation. So if the patient has a disease process, whether cardiac or pulmonary, that they are a transplant candidate and they're on the list already, and that can happen, that certainly happens a lot, and they get moved up on the list though when they go on ECMO, but they're decompensating and they have to go on ECMO. It helps them to move up on the list, but that would be bridge to transplantation. And then there's destination therapy, and that is this is all they got. This is what they have, and whatever their destination is going to be is what their destination is going to be. But now in the acute setting, especially with ECLS or extracorporeal life support, where you're taking patients who have an acute cardiac event and they're being coded, and you're doing it to save the brain and the other end organs. ECLS is really changing how ECMO is being thought of, especially VA. I mean, we're really talking about VA when you talk about ECLS. But if you're going to embark on that, if you're going to put a patient who rolls into your emergency room under full code from paramedics, and you make the decision to put that patient on ECMO in the emergency department, you really have to know what your parameters are for making a decision. Because if you don't have a withdrawal decision in there, some type of algorithm, then you can really own a lot of very long-term unsalvageable patients. So you have to be very careful when you're deciding to do ECMO that you have, there's circumstances that'll happen. Somebody's 25 years old, 31 years old, 35, 31. In fact, we have a 31-year-old now that was a postpartum event, and nothing to do with COVID. There were a lot of things happening. This young lady had 11 liters. I did the case. She had 11 liters of blood in her abdominal cavity, and that's a massive amount. And her abdomen was enormous, and it was you could play quarters off of her off of it. And of course, the baby had already was deceased in utero, and they did an emergency C-section, and then following the C-section, there was a cascade of events that resulted in the patient being in this condition. The decision was made to put her on ECMO, not necessarily because she was a very good candidate at the time. The decision was made because she was 31 years old, and that. When you do ECMO, when you are in an ECMO center, when you're in an ECMO program, when you've made that decision to embark on that technology, those kinds of things are going to come your way. So you have to be very careful. You have to have selection criteria, and you have to have, in my view, and John, you could discuss this too, I think you have to have some type of ECMO, medical level, physician level ECMO coordinator that is a kind of final decision maker of yes or no, or it's time to have a conversation with the family. Even though it may have been done, they may not have been available, a decision was made, but it really isn't the best candidate for doing what we're doing. You have to have, I think, that level in order to be able to run a successful program, because you don't want to just put this in everybody who has almost no chance of survival. Is that what you experienced too, John?
Yeah, can you hear my mic okay?
Yes, we can hear you beautifully.
Yeah, because I'm going on and out of mute in case I get an overhead announcement. Yeah, I think a couple slides back is a good slide to discuss at some point, Joe, where you're talking about, bridge to recovery, and then bridge to bridge, and bridge to transplant. Initially, almost everybody that goes on ECMO, we're hoping that we can put them on ECMO and in some way they're going to recover. You know, just about everybody is put on that, unless there's a planned slow deterioration of a transplant patient waiting for a transplant and they just can't wait any longer. Maybe that's an exception. But hopefully we put people on with a hope that they're going to recover. As that happens or doesn't happen, and by the way, that should be reassessed every 48 to 72 hours. Are we making progress in a certain direction with whatever the patient's condition is, whether it's a pulmonary, cardiac, or a combination of both? Are we making progress? And you should ask yourself that as an ECMO program at least every 72 hours, and maybe even more frequently than that. When that stops to happen, when your recovery process in whatever direction you hope you were going ceases to continue moving appropriately, then you have to start asking the questions, what other choices do we have? Are they a candidate for perhaps a lung transplant? Are they a candidate for perhaps a heart transplant? Are they a candidate for a long-term VAD? And when you get to the, when you run out of all of those options because for whatever reason they don't qualify for any of those, then you have to start asking your questions and presenting yourself with, we may have to terminate.
Yes, I hear you, and those are very difficult decisions to make, and I think it takes a lot of experience to know. You know, of course, none of us ever really completely know until a lot of times these patients, I've seen them declare themselves, you know, in a whole variety of ways, but once they're in multi-organ system failure and you start seeing, you know, a reduction in oxygen extraction and, you know, all these indicators, I think everyone knows that I think everyone knows what all of that portends for that particular patient. But anyway, these are very classic VA ECMO indications. We'll just very quickly go through the list. There's cardiogenic shock with or without MI, fulminant myocarditis, pulmonary hypertension and RV failure, pulmonary emboli or embolus, especially a saddle block, and hemodynamic compromise, cardiac arrest, assisted CPR, likely going, it could be electrophysiologic, but likely going to be an MI. Medication overdose, I've seen that happen. Non-ischemic cardiomyopathy, including sepsis-induced cardiomyopathy, that's not that uncommon. And then, of course, what you just got through discussing, which is bridge decision for transplant or VAD, or a patient who is a transplant candidate that needs a bridge to hold them over until they can get the organ. It does move them up on the list. I want to remind people of that. And then support post-cardiac surgery with post-cardiotomy syndrome, failure to wean from cardiopulmonary bypass or whatever you want to call it. In that case, you're just thinking you have a stunned myocardium and it should recover. But there's so many other nuances associated with this, and that's my second part today of my lectures is going to be on hemodynamic monitoring while on ECMO, because there's so many confounding factors and nuances associated with it that a lot of times just you put somebody on ECMO, that doesn't really solve your problem. It buys you a little bit of time, but you could end up doing even more, not doing anything to help them, but actually making it worse if you don't know what you're doing. And John, I think you talked about this last night where you discussed how it really takes a very well-conditioned team for a transfusion management program. It takes the same team experience, if you will, to have a successful ECMO program.
Yeah, I mean, absolutely. You better have a multidisciplinary approach. You better include all aspects from physical therapy, nutrition, all the way to run the gamut for being involved with every ECMO patient. If you think you're going to set it and forget it, you're going to find out real quick that is not going to work. And you need to buy yourself time with whatever it is the condition the patient has, and then go immediately to work on seeing what you can do to heal or correct that condition, because ECMO by itself, I mean, on some level, the rest of the organs alone is therapeutic, but by and large, ECMO is its own pathology, probably more so than it is a therapy, quite a bit more actually, because of the massive inflammatory response, disruptions to coagulation, all of the cytokines that are released, the complement activation. We can list on and on all the things that are triggered when you put somebody on an artificial circuit for an extended period of time, as you know quite well, Joe.
Right, and in addition to that, you get fluid shifts, you get cardiac chamber size differences or different levels of volume in them, how you're affecting them, how you measure or are able to monitor the adequacy of your perfusion, the fluid balance, intravascular fluid level of the patient, whether it's adequate, hyper or not, hyper or hypovolemic, a lot of things, and I'm going to go through some of those, John, in this conversation. So these are the most common VA cannulation strategies. VA is really pretty straightforward. You want really good access. You want really good drainage. The key here is you want to capture as much of whatever circulation they have and run it through the system. The more of it you have, the better decompressed the heart is going to end up being. You also, and there's another thing too, and Harlan, when we talk about dual circulation or differential hypoxemia, I'll talk about that a little more. But VA ECMO with femoral arterial return cannulation can be extremely challenging if you don't take into consideration what it is going to do, how that flow is going to work, and what contribution, if any, the heart is going to give or not give, and then if it will give, what the lungs are doing, and then also, you have to be concerned about LV distension. There's all kinds of things that are going to happen, and we're going to get into those, especially in the hemodynamic section of this. Now, this happens more in pediatrics, but you see the center picture. You can have the right IJ cannulation, and in pediatrics, they'll sacrifice the right carotid and cannulate it for the return, but you can also put that out in the axillary. That's a little more challenging because you have to modulate the flow going to the hand, or you'll end up with a ballooned out hand from hyperperfusion to that. And then there's, of course, central cannulation, which is the one that's all the way on the right. Traditional right atrium to ascending aorta. Typically what you see, you just use your regular bypass cannulas coming off pump. This is something you would see from central, from a post-cardiotomy patient that just had heart surgery. So this is an example of central cannulation, and there's a couple of things that are remarkable about this. One is you can see they're on ECMO, but it seems like the heart is stuffed. I don't know if you noticed that or not, but that is not really just stuffed. It does have more volume in it than I would be comfortable with. You can kind of see the dilatation of the pulmonary artery, but what you're seeing there is really more edema. And I have seen hearts that were so grossly edematous from a very long bypass run where COPs were very low, hemoglobins or hematocrits were very low, and the amount of edema that I have seen on some of these hearts has been incredible. And I've also seen them after it's been treated and corrected, and the difference. But you're not going to close this patient's chest. This patient's, you might approximate the skin, but that's going to be basically a viadrape going on there. And of course, these types of cannulations, if you have any of your purse strings have worked loose and they're not tight, especially in the aortic cannulation site, in the aorta, the amount of bleeding you're going to have is just horrendous. Now, it also looks like they put a huge catheter in the, that's the catheter in the top right on either picture. of the right superior pulmonary vein as a left atrial vent. That's a big vent. They're using 3/8-inch tubing. I mean, we usually put vents in. We just use 1/4-inch tubing and wire it into our venous access line. So I don't know. They put a big one in, and I don't necessarily think that a left. Well, we could talk about this in the monitoring section again, but a left atrial line is good for capturing your return coming through your pulmonary circulation and helping to keep the left atrium decompressed. But if you have a competent mitral valve and a slightly incompetent aortic valve, you can really end up with a very dilated left ventricle despite having this in. And I think a lot of people don't think about that or consider it. So I really prefer an LV vent versus a left atrial vent. I think it's a better option. And this is what it would look like. You see, like in the previous picture, they tunneled the cannulas before they inserted them through the skin in the diaphragm area, and then brought it up into the chest so they could close the skin. I'm not sure this patient's sternum is approximated, but certainly the skin has been closed. And it is a much more convenient way to manage these patients, I will say that. And the chest tubes, if you're bleeding severely enough, I have, and they don't want to take the patient back yet, I have hooked a cell saver up to the chest tube drain line and just gone ahead and run it over and over and over. You're still going to have to give them products, but at least you get the red blood cells, or a lot of them, back into the patient, and you do get to reduce to some degree the amount of transfusions that you're giving that patient. But it's a very busy ECMO run. It's not your standard VV that's on cruise control. So here is another example of veno-arterial. I think we've really sort of shown that. You can see there they cannulated the innominate, and on the right side, and then on the left side you see a traditional veno-venous from femoral cannulation. Now you see where they have terminated the tip of the cannula. I don't know about you, John, but I wouldn't want it there, or even on the other side. If you're going to put that in there, I want that cannula tip in the sort of higher up in the atrium, so a lot of the other holes are in the atrium too. I think that's going to be a lot more beneficial, and a lot when you start getting a little hypovolemic, I think it'll delay the occlusion of your inflow catheter from the tissue closing around it. I think if you have it that low in the IVC, I think that's going to collapse a lot faster. What do you think?
Yeah, I think you make a good point. I hope that people, our viewers, don't look at that and think that that is a pretty good demonstration or illustration of the proper point at which the cannula would go in. And Joe, I don't know if you recall, but we're working on in the future a webinar, top 10 mistakes of new ECMO programs.
Yes.
I think I proposed that idea to you, and you've already hit on two of them. One of them is keeping the colloid osmotic pressure up. I see that as a very common mistake, and this is another one too. We see this a lot, where they feed up a femoral venous cannula and they don't feed it up nearly far enough. If this cannula, if you're using the right cannula, it's going to have end hole and a multitude of side holes. So in order to take advantage of that, if that's going to be your only femoral venous cannulation, you need to feed that femoral venous cannula all the way up to basically the right atrial SVC junction.
Agreed.
So that the end hole is going to capture a lot of the SVC drainage, and all of your running side holes are going to do a pretty good job at capturing all of your IVC incoming drainage.
Yeah, agreed. Absolutely agree. But here's another example. This looks like this is a very good example, I think, notwithstanding the cannula positions, but this is a veno dash arterial ECMO. So you have two venous drainage. You have one coming from the right IJ, the SVC, one coming from the IVC. So you have two access and one return into the femoral artery. And then the next one that you see there is one access coming from the IVC right atrium and returning one to the femoral and one into the probably the axillary or the subclavian, but probably the axillary. And so that's an example of one access to return. So you have the one on the left is two access, one return. The one on the right is one access, two return. And I give a little better description of this here. And John, you gave a talk not very long ago where you discussed the dash goes where the oxygenator is located. And that was such a simple but elegant way of stating this fact. And so, because you see all of these letters and you're like, well, what's what? What does this really mean? So let's just start with number A. This is veno, so two venous access, oxygenator is the dash, and then going into the arterial circulation. The B is basically the same thing. C is exactly the same thing. The sites are just different. That's all that's changing is where they are, and that's very important to understand. You can put these things a lot of different places for a variety of different reasons. And then you have in D, it changes. Now you have V-AV. So one venous access going through the oxygenator, the dash, returning to the arterial and venous circulations. Now, keep in mind, you do that in any of those configurations where you have VAV, you're going to have a differential in resistance. So that will require you to be able to modulate the flow, particularly going to the venous side, unless the cannula is really, really small, where you have higher resistance anyway. But you really need to measure the flow on both of those returns so you get the flows you want, because that could be a real problem if you're just using one flow probe and you're not placing it, you're placing it before the Y on the Y connector or the junction where these lines split. You aren't going to know which way what the flow is to each of those lines. You really should have two flow probes hooked up in this configuration and monitoring both continuously. That's what I think, but that may be unrealistic. So part of your responsibility would be to check that every hour is what I would think. John, your thoughts on that?
Yeah, we always have two flow probes. Mainly what we do, for example, if it's a cardio help, the arterial outflow probe would be right near, it would be your main outflow coming out of the oxygenator. And then as it Ys and splits like you have there in D, you need to take a separate flow probe from another device, whether we use our CMAG consoles and we just take that, turn it on, and we just use it as a flow probe for that time frame, and we'll put it on one of these legs, which either one. So if you have a total outflow of the oxygenator of 4 liters, and you have one of these legs with an independent flow monitor reading 2 liters, then you obviously know simple subtraction tells you the other one is flowing 2 liters. But regardless of how you choose to do it, you need to know, because you cannot hook up an arterial outflow cannula and a femoral artery, which is going to be under high pressure, and then wire it off and put it into a low pressure system, which would be the right IJ, and think that they're going to distribute evenly. A vast majority of the flow is going to go down the right IJ because the resistance is obviously so much lower. Exactly. And that may not be what you're trying to achieve. You're probably trying to achieve more of a balance because you have both cardiac support and pulmonary support. And the great thing, by the way, Joe, about VAV, which I like a lot, is as the cardiac function recovers and or the pulmonary function recovers, you can modulate how much flow and how much support you're doing to either one of those. Yes. And that flow probe, what you're talking about, goes a long way to tell you where you're at and what you're doing.
Absolutely. So and then we have VV, so two venous access, oxygenator. Now you're returning both arterially and venous. So two venous access, returning arterial and venous. And then you have, and number H, 3 venous access and 1 arterial return. Now, you know, John, you may have more experience with this. However, and with that said, you'd have to put a really big, I would think that would require a cut down on the femoral artery and putting a graft on it, and then putting in either a really large cannula, if you had such a thing arterially, or just stepping it down to a 1/4-inch tubing and tying it into the graft. Could you really flow through any one? Why would you need 3 access and 1 arterial return? Could you really take advantage of that?
Yeah, you wouldn't really have a situation like that exactly. What you would end up having is more like in G, where you needed additional. Actually, I take that back. You actually don't even have it. If you look at D, if you look at D, and you look at H, I guess would be one way. Well, actually, no, I don't even see. You basically, you shouldn't be needing 3 venous drainages, because you should have had 1 should have been close to good enough, and 2 certainly should have been good enough. But then you run into a problem of how can you even return that blood back to a single aortic cannula if you're needing,
or femoral
if
cannula.
you're needing that much return flow to the oxygenator, you're not going to be able to deliver it back to the patient, and you're going to end up wiring off your arterial line and probably delivering, 2 arterials back. So you're basically needing a ton of support. If you're needing to flow something like this, you'd be needing to flow 8 liters to the patient or something like that to have that much access, and you would be totally restricted by your arterial return, because you just would be not able to deliver all that. So it'd be a little unusual that you would end up with 3 venous drainages. Now you could end up with 2 venous drainages and 2 arterial returns, and at some point you may max out your oxygenator, and you may have to do something even different if you're needing that much support. And
yeah,
this
I
is
think
a good slide,
at
Joe.
that point
we've had this slide up a number of times.
Yeah.
And what people are probably asking themselves is, why would I have any of these, or why am I choosing one over the other, and how did I get to, what do I have to know about all these different combinations? And I think we did a talk back a few months ago talking about the 2 things that you are worried about when you're doing ECMO is, am I providing enough support? In other words, do I need to flow more? And if you need to flow more, what is my restriction? Am I having very high negative pressures in my venous line, therefore it's restricting my flow, therefore I need to add another venous drainage line? Or do I have too high of a pressure trying to return the blood back to the patient, therefore I need a second delivery line? So you get down these pathways with this progress like you're showing here, based on added support and your restrictions that are preventing you from giving that additional support. That's number 1. And number 2 is LV distension. A lot of times we'll do cannulations where we're trying to reduce the left ventricular distension, which you showed a minute ago, what they tried to put in that superior venous cannula and the right superior vein to try to drain the left atrium. So either you're trying to increase your flow and increase your support, and you're not able to do it because your cannulas are too small and you need more access or more return, or you're trying to decompress your left ventricle.
Right. Or, you're trying to avoid differential hypoxemia. So you have 1 venous access and you have arterial return from the femoral artery and then also into the axillary. And so you're making sure that you're perfusing oxygenated blood into the area most vulnerable, which is going to be the obviously the heart and the brain, right? The brain first, and then the heart on top of it. So I think
I always like to look at when you're femorally arterially cannulated. That becomes to me a little bit of a side enigma all of its own, because now you're giving oxygenated blood retrograde backwards up the aorta, and now you have to ask yourself, do I have a competent aortic valve? Am I causing LV distension? And what is coming out of the left ventricle? Is it even oxygenated blood? And therefore you get into all of these different north-south syndromes and regional hypoxemia, which I think you're going to talk about. So when you put a femoral arterial cannula in somebody, you need to start asking a whole different series of questions and thinking about ECMO in a totally different way. Otherwise, you're going to end up with a very poor result.
Absolutely. So this is a, you know, I've shown this picture before, and there's a couple of things about this picture that I want to illustrate. So the two medial lines on both sides of the patient are actually venous access lines. On the left leg, you see the arterial return, and then also on the left side, you see on the contralateral leg, you see another arterial return. So this is an example of VVAA. That's what I'm seeing here. Agreed?
Yeah, I mean, it depends on where these cannulas end up. I think we've...
well, those are two femoral veins and two femoral arteries.
Yeah.
But it's a single system. It's a single pump.
Mm-hmm.
Okay. But what I wanted to point out is, if you look down on the calf, even though they do not appear connected to me, you will see that they are using NIRS to check the return or the oxygenation, the perfusion to the lower limb. And if you notice on the left leg, they have inserted a distal perfusion catheter coming off of the line, but it looks like, to me, that looks like it's on the venous line, which is weird, but it can't be. No, it's not. I see it. It's coming off the arterial. It's just a weird picture. So it's coming off of the arterial line stopcock and then going into the SFA, and that's a distal perfusion catheter. And so you have that leg required it, apparently, and the other leg did not. But that's not unusual to find a different size femoral artery on one side or the other, or perhaps even some disease, or where the cannula was inserted. There's a whole bunch of things, how deep it went, a whole bunch of things can affect that, right?
Yeah, it's interesting that they're at least they're monitoring the limbs, which I like a lot.
Yes.
Because they've got a lot of limb cannulations there, groin cannulations, and you need to worry about your distal limb perfusion whenever you start putting cannulas in like this.
Absolutely.
So I'm to see that they're monitoring, and they can compare one limb to the other. They have one limb with the perfusion cannula in, distal perfusion cannula in. The other one, they said, well, let's just monitor and see. And if you start seeing big differences, you'll see the benefit of having that distal perfusion cannula in there.
Absolutely, absolutely. Okay, so now we have common cannulation complications. This is the most insidious of them all, and it's something that anyone that's going to do, and you just got through talking about it, so you cannulate femoral venous, move it up to the right atrium, and femoral arterial. As you said, you're perfusing retrograde up the femoral artery. But as you are on ECMO, the heart is recovering because it's now decompressed, and it is ejecting, actually ejecting fairly well. But somebody has decided either to turn the vent down, or they've decided, or the patient has, let's say, severe pulmonary edema from the initial insult and is not oxygenating. And if you have that scenario, or you have somebody who has ARDS and they went into cardiac failure, so you're on VA ECMO instead of VV, but the heart is starting to recover and it's beating well, but the lungs are not working. That's the point. Then your heart, your LV, is going to pump out deoxygenated blood, and it's going to be what perfuses the brain and the coronaries. And your femoral arterial system is going to perfuse up to some level depending on how fast you're running it. And that's called, that area where it mixes, you see it purple on the picture, that is what we call the mixing cloud. And depending on how hard the contractility is or how fast your retrograde flow is, will move that mixing cloud north or south, or more proximal to the heart, or more distal away from the heart. And that is what we call Harlequin syndrome, otherwise also known as differential hypoxemia, north-south syndrome, and what's the other one that it's called? There's so many different names, but blue head, there it's on there. Blue head and red legs. So if you draw a gas, and I've seen this happen, and I'm just telling you this because I'm telling you what I've seen, so that in case you ever see it, you're like, I've heard of this before. They were drawing the arterial, they had a femoral arterial line in for measuring the pressure, and they were drawing the gases from there, saying the gases are great, but very, 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 very bad. And I talk about this in part 2 of this lecture, but I'll just talk about it now as well. If you are cannulated on VA ECMO in either femoral artery, it is absolutely 100% essential, required, standard of care to monitor your blood gases of that patient from the right radial. Why the right radial? Well, the right radial is the farthest measurable site away from your femoral arterial perfusion cannula, and to get to the right radial, you have to go all the way around the arch where the head vessels are, up the innominate to get here. So this is where the right radial is the only place you should be monitoring blood gases on a patient that is on VA ECMO with peripheral cannulation and your return coming retrograde from the femoral artery. John, what say you?
Yeah, this is another mistake. I saw it on my travels a few weeks ago, but just to reiterate what you just said so people understand, the right radial artery is an immediate takeoff of the first most proximal arch vessel closest to the heart. And if that one is fully saturated, then your right carotid is being saturated, and of course the other arch vessels are being saturated. So you're getting good brain perfusion. You're still not 100% assured that you're getting good coronary artery perfusion, however, because the mixing cloud could perhaps stop in between the coronary arteries and that first arch vessel takeoff. But it is the best that you can do. So in answer to your question, you know, Joe, I was at an ECMO site just a couple weeks ago when I came to relieve, and the relieving perfusionist said to me, oh, by the way, we put in a femoral artery cannula. And apparently they didn't like, there was a damp reading on the radial artery.
Yep.
And I immediately rolled my eyes about, please don't tell me you're drawing now blood samples from your right femoral artery, because we were on VA ECMO, just like you said. And thankfully, they were using the femoral artery as a blood pressure reading and still drawing the blood gases from the right radial. But that sets up such an easy mishap waiting to happen 2 or 3 shifts down the road when I'm no longer there and different people have traveled in and out, and people just say, oh, just draw it from the right femoral, not thinking that that is not going to tell you what you need to know at all in terms of a femoral artery cannulated ECMO.
Right, so this is exactly, so here's the cartoon, here's the heart, here's the ascending aorta, your first branch off is your innominate. Your innominate splits, of course this isn't a perfect diagram, but your innominate splits and goes to your right carotid and then to your right subclavian. So if you're perfusing from down here up, then even though that theoretically is possible to have the mixing cloud right here just above the coronaries, it's probably going to be pretty purple. It'll probably be likely, if it's good out here, it's good. It's probably going to be good for the coronaries as well, I think. But if you're perfusing this way, you see it comes up. Now here's your arch vessels here. Here's your left subclavian. Here's your left carotid. Then your innominate, and it has to get to this for sure to have your gas, your blood gas measured all the way out here, to have it measured there. And if it's a good PO2, not just a marginal PO2, but a good PO2, because I think if it's a really good PO2, the likelihood is you know the coronaries are being well perfused. If it's really kind of just marginal, like your circuit is pumping in 300 and it's 90 here, I would be concerned. I would start to become concerned about that. So you just have to kind of pay attention to it and understand how the circuit works, and that's what you have to do. You really have to think. There's no way to really explain it all, but you got to think. And then I've got a question here. What is the recommended flow for VV ECMO in adult patients? How much maximum RPM can we have? So that's a very good question, and I'll do my best to answer it, and then I think John can answer it. I'm a goal-directed kind of guy, so for VV ECMO, there's several things that you're going to have to take into consideration, and that is, what type of cannulation are you using? Where are the cannulas positioned? How much recirculation do you have? Because sometimes turning the flow, the RPMs up, actually makes the recirculation worse. And there are methods for figuring out kind of you have a lot of recirculation or not, especially if your venous access saturation PO2 is coming back very high. And it's counterintuitive. You really want to kind of turn your flow down and reduce the amount of recirculation, which increases the effective ECMO flow. So as far as how many RPMs are recommended, I think when you're really having to crank the RPMs up, there's a cannulation issue somewhere. Either the cannula is partially obstructed, you've got the inferior vena cava collapsing around it, for example, because the patient is hypovolemic. That I've seen happen, and it's just enough to where there's resistance, but it's not lufting, or it's not, jumping and chattering. So I think that becomes very obvious when that happens. But I believe more in trying to find the most effective place you can be to have flow and have good oxygenation on the arterial side, but not having to do it by increasing the FiO2 on the vent, because your goal is to turn that down. So I think you have to take into consideration a lot of things, and high RPMs, of course, you're going to get a higher level of red cell destruction and other blood component destruction as well. So you have to make sure your cannulas are the proper size. You have to make sure they're in the right place. You have to make sure you don't have high recirculation. And you have to think all of those things through and make a decision. Does this patient need cannula reposition, or does this patient need an additional cannula? And if it does need an additional cannula, as you were saying, John, and you're running high RPMs, is it because of volume, and I need to get this patient's volume up? The patient may look like the Michelin Man, but that doesn't mean their intravascular fluid volume is correct. So I think having bedside echo is very important to really look and see what the volume status is of the patient. Getting blood back out of the extravascular space into the vascular space, and managing any kind of excessive volume with some type of ultrafiltration, whether it be CVVH or just a hemoconcentrator in the circuit. I don't like that because I don't think it's controlled enough, but you can do it. You can do it that way depending on what your limitations are. In the case of a 75-kilogram patient, so good question again. I think that if you have taking blood from femoral venous lower IVC and from IJ and giving to RA through another femoral vein. Yeah, so the amount of flow you need is the amount of flow that you need in order to get your arterial saturation to a point that you are comfortable with. If you're happy with a saturation of 92 or 93, 92 is kind of my floor. I don't like to be below that. I know some people will go down to 89. I don't like it. So let's just say whatever your number is that you want it to be, I would flow enough to have that number. If you can afford luxurious flow and you can get it to 100%, then I would get it to 100% if you can. But if you got it to 99, I'm not going to keep trying to get it to 100, because that's a really good number. Number one, you're going to be giving great O2 delivery to the tissues in that particular case. And if you keep trying to go higher, well, when you get to 100, and then you're just going to be looking at the PO2, but that's such a small contribution. I think you can end up just creating more problems for yourself in regards to the negative impact of just having jetting and all of the things that happen in extracorporeal circulation that isn't good for the blood. So I'm a goal-directed guy. This is what I want, and I'm going to do what I need to do to achieve these parameters. That's basically how I would answer that question. John, do you want to add to that?
Yeah, I would take a step back and say, okay, if you're going to go on VV ECMO, and you're wondering what the heck should I be flowing so I can do a good job here, the first thing you should try to do is capture somewhere between 40 and 60%. Your flow should be somewhere between 40 and 60% of the patient's total cardiac output as a good starting point. In other words, if the patient's cardiac output is 9 and you want to capture, 40 to 60% of that, you want to flow somewhere around, 4 to 5 liters as a good starting point. You're probably going to be pretty darn good if you do that when you draw your first blood gas and see that your PO2 on your arterial is actually quite good and your saturations are quite good. Now that's a starting point. You may have to go up and you may can afford to come down. So you first want to make sure that you're able to flow at least that amount. Usually if you're able to flow and capture that amount of cardiac output, you're going to support your patient with very high SaO2s, and you're probably going to see 99 to 100. Now let's talk about that for a minute. What is acceptable if you feel like you've maxed out what you can do and you're still not at 100? If you can stay above, in my opinion, above 85, and some people would use 88, I would say if you're doing everything you can and you're 88 or above in your arterial saturations on your monitor, then you're doing everything you can. You can hold at that point without having to, try to strain your circuit any further or add any cannulas. Hopefully the patient's lungs will get a little better and you'll start having to have better saturations and you'll be able to even turn the ECMO down after a while. But if you start having saturations below 85 and you've maxed out what you can do there on your VV ECMO, you might have to look into doing some other things. Now, as far as what RPM in specific you should be running, if you're not monitoring your minus venous pressures, if you're not monitoring, how much negative pressure you're drawing, that's a disadvantage of not having that type of monitor hooked up like a cardio. You keep turning it up, and at some point you're going to have chattering, and you're going to be limited by your flow there. But you really, if you're running a VV ECMO and you're wondering, am I overflowing or underflowing, try turning your RPMs down. Sometimes you turn your RPMs down and your flow will actually stay the same or even go up. And that's because you're overstraining your negative pull and you don't need to be having that high of an RPM. If you turn your flow down and your SpO2 stays the same and then you can see that you're actually overflowing as well. If you turn your flow up and your SpO2 goes up on a VV ECMO, that's not a good sign. That's just telling you that you're mixing and you're overflowing your cannulas, and all you're really doing is increasing your recirculation through your own VV circuit.
Right.
So you can, once you get the patient supported, is number one. Adequately supported meaning good, decent SaO2s and PO2s on your blood draw from a right atrial line. Then if you want to know if you're overdoing it or underdoing it, you can adjust your VV flows and see the changes that are gonna happen. And I think most of the time you can probably turn your flows down more often than not and decrease some of your surface area inflammatory responses, as well as maybe some hemolysis and stuff like that. If you're overflowing, you're not doing a whole lot of good if you're supporting your patient already. You're already doing what you can do. So those are some things you can look at.
And those are, John, those are excellent points. And I wanted to also add, and this came from our friend from down in down south, down in the down under in Australia. And we also have some very good comments from a physician in, I'm not sure where they're from, but regardless, the Karma Police is our down south friend. Maybe you could tell, if you type the name, I'll know who it is. But with that said, he said, would you recommend mild hypothermia to compensate for reduced arterial oxygen sats? And I responded on the chat with absolutely yes. I mean, that is what I will do that, number one. And number two, is there any special monitoring for COVID? And this came from somebody else who has an ECMO program somewhere else. I don't think monitoring, I don't know of any monitoring, but if you listen to my next lecture, it's, okay, so from India, nice to meet you. Is it Dr. Das? I'm not sure, or Samnath. But with that said, not monitoring, but it seems that proning has been extremely helpful for us with our COVID patients. And I don't know if that's because there tends to be more lateral posterior lung involvement in the disease process, but we have seen even patients on ECMO, we have proned them even without a proning bed. We have done it, we have flipped the patient on the bed on VV ECMO with a single IJ dual lumen catheter in, and have had success with that. And we've seen real improvement. The only thing, John, I would say is I'm not comfortable with 85. I'm not comfortable with 88. I mean, really, I'm not comfortable with under 90. I'm not comfortable with under 92. I think that's just, when I calculate out the DO2I between, 95 and 85, that's a big difference. So I know that's what the protocol is, and I accept that, and they have good outcomes, and I can't argue the point in that regard. Just I am not comfortable with it.
Well, remember, you have a fourfold oxygen supply capacity before you reach, desaturation, right? Because normally you would have a 99% saturation of arterial, end up with a 75% saturation in your venous. So you still have a threefold extraction ability. So if you only have a 85 or 90 and your venous sats are 55, you still have plenty of oxygenation. Your tissues are learning to, or having to, extract what they need, and you should be fine. But when you start getting into the mid-low 80s, I agree with you. A lot of people start to think, this patient goes down any further from here. Our PO2 is like, if you look what your PO2 is, an arterial saturation of 85, it's not too great. It's probably about 60 or something. And so, yeah, that's where
pretty
people
scary.
Start to get
It's
nervous.
scary.
I did want to comment about the
Well, I just don't think it leaves you.
There.
I just don't think it leaves you any room for error. That's my issue with it. May not necessarily be that I don't think you're getting enough that you have enough oxygen. I just feel like it's just such a tight window, and I like to have a little more cushion than that. But before, and I know you want to talk about the hypothermia, but you also have to take into consideration where your vent is. And there's nothing wrong. Your goal is to certainly get the vent FiO2 down. You want to get it down to 40% as best you can, as soon as you can. But don't sacrifice oxygenation of the patient and their brain in particular and their other organs for going to 60% on the vent. Do what you have to do to oxygenate the patient. Take advantage of if they have any lung capacity, prone them, and if you get good numbers in that regard, then that's going to be a period of time that you can maybe come down on everything and even the vent from 60 to 40 if you want to. But then when you go back supine, don't be surprised when if you have to go back up on the vent. So you have to think about that, I think, in order to do this. Or do you want to not do that and put another cannula in? And I know you still want to talk about hypothermia, but I don't want to miss these people, their questions. So a perfusion, I think a perfusionist from Italy says, speaking about the V-AV ECMO setup in her center, they use a secondary centrifugal pump on the outflow line directed to the right IJ to manage the blood flow. So that's what they're doing, and that actually sounds like a brilliant idea.
Well, that's not something that I've seen, but I'm not sure why they're putting an additional centrifugal pump just to flow through the right IJ, where they feel like they can control it better that way, I guess.
I would assume that to me is what I would think. If we're right, Andrea, please let us know. If we're wrong, please let us know what the reason is. But my suspicion is that it's so that you don't have to sit there and modulate the flow. You actually can control the flow going to where it is through that centrifugal pump.
I mean, they still have to have a flow probe on there
Sure.
to tell them what it's doing. I mean, maybe they've tried to do the Hoffman clamp, clamp down the line, and it's frustrating. It's very tenuous. You can do a small adjustment and it changes the flow, and maybe they've done that, and now they decided if they put a centrifugal, I guess it's a centrifugal pump, or is it a roller pump they put in there? Maybe.
I would imagine a centrifugal.
Yeah, that they feel like they just have exact control over it, I guess. That's interesting. I've never heard that. And while you're waiting for your next question real quick there, Joe, the hypothermia thing, if you're going to put ECMO patients on hypothermia just to decrease their oxygen demands, the problem with that is the patient is going to have to be very anesthetized and paralyzed, because otherwise they are going to go into shivering and they are going to consume a lot more oxygen than what you were trying to prevent.
Paralyze
very
them.
Careful.
Sedate them and paralyze them.
Yeah, well, then you can't interact with them, and you can't do good neurological assessment, and you can't do any PT and stuff. So,
well,
yeah.
if you're that critical, that tenuous, that you're considering the need to use mild hypothermia to make sure that you're reducing metabolic demand enough, basal metabolic demand enough to deliver the oxygen you need to the tissues. Yeah, I think that's, I agree with you in the sense that on a patient that you're trying to get to that point, but if they're that critical and they're that limited in any of their own capacity, and you can't meet the demand that they have, deep sedation and paralytics, and that's what you got to do.
Yeah, it's funny. I've actually not seen that. I've not seen us deeply or cooling people to 33 or 34 or whatever you might be talking about, just because we couldn't meet their oxygen demands. I haven't seen that hardly at all, but it's interesting. I liked it.
So a question for you, John. What's the indication and timing for unloading the heart during FEM VA ECMO, and what is the best technique for unloading the heart?
As soon as possible. You don't want LV distension for any amount of time. If you pump cases with a surgeon in a regular open heart case, the second that he or she sees that the heart looks like it's distending out, they let you know instantly. So there's no toleration, very little tolerance for LV distension. And one of the best ways, one of the most common ways we see now is that people put an Impella in. That's usually the first thing that happens a lot of times. Usually that'll do the trick pretty well. If that's not doing the trick, then sometimes we go to an LV apex drain cannula, sometimes in that left atrial, but I think more often where I am, we see an LV drain cannula. But nowadays the Impella seems to be able to, empty the left ventricle pretty well. You can usually turn that up to a couple liters flow at least, and that'll keep your. And then the best way to assess it is through echocardiography and watching what your LV looks like, and you can look at the septum and seeing if it's bulging out, and you can just see real easy on echo what your LV distension looks like.
Absolutely. So go ahead and throw my slides back up, and let me just show you this. So this graph here shows you distinct effects of circulatory support devices on LV wall stress. And what you see is VA ECMO with peripheral cannulation, how much wall stress you have. Tandem heart and Impella was better in this, the 5.0. But of course, I'm not. I like Impella. I think it's, again, I've said it before. I think it's an overused device, but we're not going to have that discussion today. I think it has an appropriate place and it's a good device when used appropriately. But here's what you were talking about. If you look at on the right, VA ECMO without an impeller or some other way of decompressing the left ventricle, you can see the left ventricle is grossly distended, and you see that the interventricular septum has been displaced over to the right ventricle. That is very bad because there's so many bad things that happen with that, including, and probably most significantly, you have very limited coronary perfusion to that muscle. So you have a lot of bad things happen. Plus you're stretching it, and of course we all understand striated muscle of the heart, the way it's designed, and that can create an unrecoverable event. And then on the left side, you see that the impella has been inserted, and you can see that the septum is now back in the position it should be, and the left ventricular chamber size looks more appropriate for VA ECMO. And I don't want to go through all that. This is a septostomy, event that gets put into the femoral vein and goes up, and it's like a tandem. It's similar to it could be a tandem heart catheter. But basically, you notice that, again, if you had AI and a competent mitral valve, it's very good for capturing the pulmonary venous blood. It's not so good for really decompressing the LV, at least in my opinion. So I do think that either the apical drain or the impella, either one, is a much better option. There's for right heart. I kind of want to get through these. These are indications for VV, and I've just very quickly, there's a single cannula because we're running out of time, and we have another one to do, but let's see. I wanted to talk about this very quick. Cannula size. Bigger is not always better. We've been telling that to girls our whole life. Avalon for adult comes in 27 to 31, but there's a variety of sizes, but that's the most common that you find in the adult world. I have a patient right now that I have a 27 in that I'm flowing over 5 liters, actually, over 5 liters. So I think we tend to oversize cannulas, and I would rather undersize them, and if I need another one, put another one in. That's my view. John, I'll let you elaborate on that in a second. On the VFEMs, they, 18 to 22, they have a 24, but I've never needed anything more than a 22. And I think when you get into the 24, 26, you try putting it at 28, I don't think that helps flow at all. In fact, I think it really makes it worse because you're really up against the wall of the vessel, and I think that reduces the amount of holes, ports that you have to drain the patient with. So I don't like oversizing. I'd prefer to go with a little bit smaller, but you can be too small too. And then on the opties, if you do femoral arterial, I would say 18 to 20. If you put a 22 in, certainly you're going to have a lot less resistance than an 18. But there's been, again, and we do big people. Like in Texas, most of our people here are very big, okay? It's not like Italians. A normal BMI for us is over 30. Anybody under 30 is a rarity at best. Really, we're looking at 35 most of the time. So we're a very obese society, but I've never really needed much more than a 20. John, I'm not sure what your thoughts are, but smaller is also better to mitigate distal perfusion issues when you are in the femoral artery. Also, where you place it is very important as well, where your insertion point is. So those are my thoughts on that. John, what do you think?
I'm going to agree on the first and third and push back a little bit on your second one there with the femoral venous sizes. The two biggest centers that I go to really try to go with a larger femoral venous, 23, 25, if possible, because when you go with smaller, you have to end up, what you said you're okay with, is putting in that second additional venous drain cannula. If the theory is, if you put one large enough, it is harder to do, it's a little slower to do in the beginning, but once you get it in, you usually don't ever have to get to that second one nearly as often. So there's two theories, get the big one in to begin with, and you won't have to go back and put a second one in. But on the Avalon and on the femoral artery, there, I would agree with you, those sizes are pretty optimal most of the time.
Mm-hmm. So I would say, and I see your point, and I think your point is well respected and understood by me. If you're going to put the bigger size in, then I think you are very much obligated, and we discussed this earlier. If you're going to do that, put the tip at the RA-SVC junction. Don't leave it in the inferior vena cava. Don't put the tip at the IVC RA junction. Put the tip all the way up. And so that's my view on the bigger cannulas. But you should do it under, I think, fluoroscopy to make sure you are exactly where you want to be. I do think that makes a lot of sense. Something we really didn't even talk about. I think when you place these cannulas, you should put them out, get a marker, use the marker, make sure you measure about where you want to be, put it in, and then use fluoroscopy to confirm you are where you want to be, not too far up, but not really low. And I think that's critical for the bigger cannula, in which case I think your point is 100% correct.
Well, it's definitely a two-pronged thing. You can't just take a big cannula off the shelf and put it in and say, okay, it's fine. If it's not placed right, it's not going to do you nearly as good as you're hoping. So, and that is another very common thing we see, is that the tip of that cannula doesn't make it quite to that right atrial SVC junction. If you do that, you'll find that your drainage is quite a bit better, and you'll be glad you had it placed right. It's a big difference.
So we have two other questions, and then we're going to take a short break and go on to the next section of this on the hemodynamic monitoring on ECMO, which I think is going to be really good. So first, from our friend in India, somebody else. I don't know where they're from. Anand Kumar. Sir, you have any case experience of heparin-free, anticoagulant-free ECMO? Not any that's good.
Well,
John?
We do a lot of VV ECMO. We don't anticoagulate hardly anybody anymore, provided your flow is above 2.5 liters. So a lot of places, and I say a lot, it's probably about 15 to 25% of places now, and it does go against, by the way, ELSO's recommendation. I've got to point that out. ELSO has not recommended that you ever do non-anticoagulated ECMO. However, there's a lot of experience in a lot of places with VV ECMO, because your bleeding complications drastically are reduced when you can do non-heparinized VV ECMO. I'm assuming that everybody's using a bio-coated circuit out there.
I cannot disagree with you more. I cannot possibly disagree with you more on that. I think that subclinical coagulation, consumptive coagulopathies, all of those things are very real and can happen. However, you're doing it and having good success. So my recommendation to you, Anand, is don't do it. John's recommendation is, I'll let you give your own recommendation.
You can do VV ECMO without anticoagulation as long as you have a bio-coated circuit and you're flowing above 2.5 liters. You can do it all day long with tremendous success, and it's hundreds and hundreds of cases have been done. It's not just my center. I see it all over. But as I said, ELSO does not have it in their guidelines to be doing that.
Can I challenge you just a little bit?
Yeah, I mean, the reason why a lot of people, real quick, the reason why us and a lot of people go to non-heparinized VV ECMO is it happened to us. We didn't happen to it. The amount of bleeding complications where you have to DC the heparin for 24 to 48 hours to stop your bleeding complications was so prevalent that it eventually became to where we just didn't do it at all. And a lot of people had that experience. But go ahead, what were you going to say?
Well, I'm going to challenge you just a little bit, John. I have to do that. First, our friend Somnath, he's asking how much APTT value to have, should you maintain for COVID ECMO. You know, I know there's a lot of discussion about COVID, and we're doing a lot of them. we're staying basically within the same guidelines we have all the time. We go 1.5 times control. So a PTT between 55 and 65, somewhere in that range, we're very comfortable with and having very good results. So that's my answer to you, is I would do 1.5 times your control. That's where we do it. And we usually start off with a very small bolus of heparin to get everything started. And then I like to start it out, depending on the size of the patient, obviously, but I'm somewhere in the neighborhood of 500 to 750, and depending if they're very, very big, 1,000 units per hour. But usually about 500 to 750 units per hour is where I'll run it. And if it looks like it's running high, I'll stop it, taking into consideration a 90-minute half-life of heparin, and then stop it for about an hour, then turn it back on at a lower level and check it every 4 hours. And then as it continues to become stable, I'll let it check it every 6 hours, and then we'll eventually move to just once a day. As far as if it's low, if it's trending down, I don't like to go up on the rate. I like to instead give a small bolus, maybe 500 units, 1,000 units, give a small bolus and let it bump it back up again, especially if that trend downward was over a significant period of time. Because I think when you turn it up, the rate up, it just goes up and up and up, and you end up like this, where instead you could just have sort of it's like this, and you just hit a little bump, and then it stays like that for a longer period of time. That's how I manage it. But John, and I've got two other things I got to ask. We avoid the use
with the COVID patients who are not had their chest open or post-cardiotomy and things like that, and being hypercoagulable, you should be able to heparinize your patients and keep PTTs in the 60s. You shouldn't be having a whole lot of bleeding complications. So when I was saying that, I was talking about our many years of experience previous to COVID, where you had patients coming out post-cardiotomy and different things that had bleeding issues. But
we're not making any. We're not increasing our heparinization protocol for the COVID. I'm not seeing these patients on our ECMO that are COVID having thrombotic events. We're not experiencing that. Our heparin management seems to be working just fine. Andrea says they avoid the Hoffman clamp because we think that you can have higher risk of blood clot formation in the area just before the external clamp, and that's a good thought. In particular, I think it's turbulence too is bad. In particular, when we run the ECMO with low or without anticoagulation. So they're doing it without anticoagulation. Okay, so I think they're doing it without anticoagulation. But I'm going to challenge you. You keep saying that we'll do it with VV ECMO as long as I have 2.5 liters of flow. But why won't you do it with VA ECMO?
We actually have done it with VA ECMO, but again, you're really okay. The big difference between VA, we've done it with VA ECMO before. If the patient is bleeding,
though coagulopathic, really they're not going to bleed.
But
that's different. That's not the same thing. If they have a normal coagulation profile,
then we don't do it with VA. We heparinize all VAs.
But how does that make sense?
It's a big difference, because on VV, if you have any microembolic events, at least it's going to the lungs. With VA, you can't say that.
Which are already hurt. So let's hurt them some more. Okay, look, I'm just going to tell, I love you, and I know you have good results. I'm just telling you for the record, on this TV screen, I'm not going to do it. That's it. I'm not doing it. I'm moving. I'm going to go to find another job. I'm not doing it. I can't do it. I think I don't agree with it at all. But hey, you have good outcomes. You're a big ECMO center. You do way more ECMO than I do, and even your Italian friends now. This must be a plant on your part, I think. The mobsters. You got the mobsters.
ECMO centers will not heparinize their VVs, or they will, and at the first sign of a bleeding complication, turn off the heparin. It's about 15 or 20%.
But I mean, why should you have a bleeding complication with a simple VV ECMO?
Oh, you do. You have over time. You have GI bleeds. You have head bleeds. You have bleeds from cannula sites.
Okay.
All
right. We're gonna have to agree to disagree on this one. Okay. So the next section of this, We're going to take like a very short break. I don't want to take too long of a break today because I've already run over time. Great questions, though. This has been such an incredible interactive panel. I've really enjoyed this a lot. I would love for you guys to just call in. We need a number that they can call from Italy and from India for free, okay? Can we get that? Yeah. We can? Okay, we're going to get that. We're going to have a new number that's going to be a toll-free international line. That's coming up next. We're going to add that to this system because I want you guys to call in and be on the air. Okay, how about, what do you think, 6 minutes? Yeah. Okay, we're going to take a 6-minute break. In fact, don't run things. Just put the overlay up if you don't mind. I'd rather do that. And John, are you able to stay for the second half as well?
Yeah, so far I'm good. As long as I don't get called away, I'm good.
Sounds good. Okay, so 6 minutes. Let's do it.
All right, sounds good.
Thanks, bud. Okay, so we're back. John is almost back. He has, like I said, he's at work, so he is just doing something, covering something real quick, and he'll be back, he said, about 2 minutes. While he's gone, I'm going to answer a couple of questions before I start my presentation, and both questions, it appears, are they're from two different people, but they're basically the same question, and it has to do with post-cardiotomy patients weaning off bypass and having big problems with bleeding. You know, what can we do about this problem? And look, I mean, that's in this one here, VA ECMO support post-cardiotomy patient, but we can't handle the bleeding problem. Can you advise on tip for this situation? Well, you know, this is a big problem, and I do want John, is he back yet? I do want him to participate in this, but I'll give you basically my very quick overview on this. And I've seen it a lot. If you can make sure that your central cannulas are well secured and you can treat the platelet count, your platelet count by giving platelet transfusions, giving cryoprecipitate, giving fresh frozen plasma, making sure that your hemoglobin or your hematocrit is at a good level. In these patients, I would much prefer 30 over anything less than that. I think it makes all the difference in the world. And if you just have general coagulopathy, that's just going to take some time. Now, a patient like that, I'm not going to give, we're certainly not going to give protamine, right? You can't give protamine weaning off pump and transitioning to ECMO. You have to suffer through what you're experiencing until the heparin level comes down enough to where you can get control of some of this. Making sure that you can approximate the skin or just use a Viadrape if that's what you want to use. That happens a lot. But you want to have something in there that you can suck that blood instead of into the atrium chest tube chambers. You want to make sure that you have it going to a cell saver so that you can reclaim that blood. Now, you can't the products. You're still going to have to be administering those as time goes on. But I have seen a lot of bleeding resolve that has been general coagulopathy when you treat it well. I would certainly use TEG. TEG is is a very valuable tool in this circumstance to make sure you're transfusing the right thing. But you want to keep your hematocrit up. You want to keep the viscosity of the blood good. You want the viscosity up. You want to check your TEG. You want to make sure that you're keeping your COP or your colloid oncotic pressure and osmolality normalized to reduce the third spacing that occurs, because they will bleed more when they do that. And you check the TEG and make sure that you're transfusing what is needed to get a more normal coagulation profile on your numbers, and then it's time. So the patient will probably need a washout, but when you have excessive bleeding, just massive amounts of bleeding, and I've seen that too, it is almost always the arterial cannula, the aortic cannula is bleeding, or there is something else that is pumping. But everybody gets tired. They're done with this case. They can't do anymore. You pack them up and take them to the ICU. Hope that when they put the darkness on it, that the bleeding is going to stop. And frequently it does not. And then you just have to get everybody sort of recentered. You're going to be busy transfusing, and then you have to take them back to the operating room for a washout and exploration, and start making whatever little corrections you can make. It's really it's a time game for me, and but that's what we see. And that's my answer to your question. I hope I was able to answer it well, but that's the best answer I can give you. John, are you there? So, John, I just got through discussing, and I'd like you to just tackle it as well independently, a question from a few different people that on their patients that they fail to wean off bypass going to VA ECMO, that they have had a lot of problems with bleeding and almost to the point of being nearly unmanageable. And is there anything we could do to help them with that? I sort of answered that question, but if you want to, why don't you answer that question as well and let them hear the two different perspectives?
Well, I'm coming in a little bit, I guess, after your answer, but okay, so if you have a patient on bypass in the OR doing poorly, they decide to go on VA ECMO, what do you do with your heparinization right at that point now that you're on ECMO? You've still got an ACT of greater than 480. What is your plan? What are you going to do next with that?
What am I going to do?
Or what is the caller going to do? Are they going to leave it?
Yes. I mean, I think by and large, I think nobody's going to, I mean, I'm not going to give, I wouldn't recommend giving protamine. I told them it's a waiting game. You just, heparin has a 90-minute half-life, after about 450 minutes or so, 560 minutes, you've lost, the heparin is gone. But of course, you can always give, the prothrombin. You can give you could give factor 7 if you thought that was the issue. But from my perspective, John, my whole point was that I think most times when the bleeding is that excessive, it's a cannula that's leaking. But everybody's exhausted. The case is taken forever, and they just want to get them to the unit now. And most of the time, you end up taking them back to do a washout, and you find these little things, and you just have to take the time to do it. But sometimes after the case has beaten you up, you just can't see it anymore. You can't find it. You can't deal with it. You just want to go, and that does happen. So my solution was give it time, let the heparin start to wear off. You're going to be busy. Give products. Use TEG. Use a cell saver if you put a Vidrape, or even if you close the chest, to reclaim the bleeding that is occurring, so at least you give the red cells back, and then give appropriate products to try and get their numbers at least normal, and then it's really just a waiting game. And make sure you have great cannula site integrity so that the cannulas are not bleeding, because that's a big problem.
Well, are they staying on central cannulation? If they're staying on central cannulation, they shouldn't have cannula site bleeding, hopefully, but they need to find out what the source of the bleeding is. So now, if you have a fully heparinized patient and you're not going to reverse any of the protamine, which I know is an extremely scary thought. However, we do have an enormous amount of experience with reversing 50% of the heparin with protamine while on ECMO, and I've seen that done. I'm sure that's probably not in anybody's recommended guidelines, probably not in anybody's recommended protocol, but there is a technique where you reverse very slowly 50% of the heparin with protamine. But besides that, time will let it wear off. You need to do the TEGs, as you said, and give the products that are going to try to bring your TEG as close to normal as possible. But with that much heparin on board, what the TEG is going to show, your R is going to be very, very prolonged for starters.
Yes, agreed. But at least it helps you, I think, as it continues to improve. You're going to empirically give products. I said you really want to make sure. I like a hematocrit in those patients above 30. I don't like them to have Kool-Aid circulating around them. I think you really have to address and manage all of the third spacing. I think that makes coagulopathy worse. So I think high hematocrit or higher hematocrit, good COP and osmolality control, and then also making sure that you address any surgical bleeding and that you have good integrity of your central cannulas, because I've had it happen to me several times where the arterial cannula was bleeding horribly, and and we brought the patient back and started correcting these things, and things just got better. It's a waiting game, basically. It's just time. You're just busy for a period of time until you can get all of the coagulation factor derangements under control, is what I think.
I think you should try to get as good as possible in the OR. Go ahead and stay in the OR a couple, 3 more hours and get things, at least quite a bit better. Because if you just send over to the ICU and hope for the best, you're coming back. The chest tube's going to drain 1,000 an hour, and you're going to be coming back in a few hours anyway, maybe sooner. And by then, if you'd stayed in the OR, you probably could have continued to address some of the surgical bleeding, continue to give the products, and watch things begin to improve in the OR. It's painful. It's already been a long case. You're on ECMO. You weren't expecting to be on ECMO. You bought the farm, and at this point, you just got to stay with it until and tough it out. Because to send to the ICU when things are a mess, they're not going to get much better in the ICU very easily.
I agree. I've done it a lot of times, though. I've seen it happen a lot of times, John.
Oh.
That's not an uncommon phenomenon to occur, and it sounds like it occurs in other parts of the world too. But be that as it may, I think your advice is very good. If you can stay in the operating room, just pack it, and then tell the surgeon, go take a break. We've got this until and let them de-stress themselves and come back, as opposed to all of the hoopla that's associated with moving this highly unstable patient and then having to move them back. Just stay in the operating room and deal with it, because you will make the rest of the time for that patient and everybody else that's taking care of the patient much more sane at the end of the day. I don't like giving depending on the cause of the coagulopathy. I mean, if the coagulopathy is being caused by platelet or from factor deficiency, then I don't like giving these like factor 7 and the prothrombin and all that stuff, or the other stuff, the K, what is that other, K-Centra? Yeah, that's the name of it. I don't like giving that stuff, because I don't think you got to address the issue of the product deficiency is what you need to be addressing, not giving that, unless the cause is true coagulopathy. Now, if I think it's hyperfibrinolysis, Amicar or Transex is certainly a good option as well. I don't know what you do with that.
Oh yeah, absolutely. But some of your K-Centra and your different things have those heavy factor 7, I think it is, in there, and things like that. And a lot of times, if you boost up the patient's factor 7 and a couple other factors that are in those ingredients and those drugs, you'll see some improvement. But I would caution against one thing. K-Centra on ECMO is very, very risky. You have about a 10 to 15% chance of sudden clot off of the ECMO. And you don't know if it's going to happen. You just have to sit there and have a circuit ready, because whenever we give it, we're on the edge of our seats for the first 30 minutes to an hour. And if it doesn't happen, it's not going to happen. But when you give that K-Centra, sometimes, wow, it just clots off the whole circuit instantly sometimes. You just never know.
Agreed.
So it's really risky on ECMO. Very
good. Okay, so let's go on to my slides. I'm going to try to blaze through this next set of slides, hemodynamic monitoring and ECMO. This is an article out of, I believe it was, let me see, it was out of Cologne, Germany. And I don't remember the journal it was in, though. I think it was thoracic surgery. I'm pretty sure. I think it was thoracic surgery. However, let's just very briefly go over what we already have talked about a billion times: indications and contraindications for use of ECLS. Let's just do the contraindications, because everybody knows what the indications are. But if you have multi-morbidity organ dysfunction, advanced multi-organ failure inclusive of sepsis, signs of an active bleeding, which is intracranial or lung, you have a pulmonary hemorrhage, please don't do ECMO. Signs of severe neurologic disorder, advanced age, and frailty, and that's somewhat relative, so take that into consideration. You should restrict access to VA ECMO or ECLS if you are morbidly obese and more than 3 to 4 times your ideal body weight, or you have severe PVD, or you have contraindications for anticoagulation. Now, I will say that's relative because, John, you're saying you can do this without anticoagulation, and in this case, they're saying that you should restrict the access, but it doesn't say that it is a hard and fast thing. So, maybe things like that are changing. And then concerns that we have about ECMO. ECMO usage has increased substantially. There's no doubt about that. And I think you're going to see it continue to increase, especially since we've had this latest episode. Each one of these episodes, even if it ends up that ECMO may not have been that beneficial to a large enough number of people that had developed COVID-19 associated pulmonary failure, what we have learned through this period of time is going to transcend those patients and is going to have an effect on how we manage other patients for other problems in which ECMO has already a very robust survival rate, and you're going to see that improve even more. So I believe that ECMO usage is going to continue to climb, certainly nationally, and I do believe also internationally. There is a very strong association, however, and this cannot be understated, between hospital experience and outcomes. If you do one ECMO a year, you cannot possibly expect to have the same outcomes as somebody who does 100 ECMOs per year. There's just no way, or even more than that in some cases, but there's no way. So you really have to consider your capabilities. If you do very few but need the capability because you can't transport or get somebody there fast enough to initiate it, and you want to initiate ECMO, but you have a plan to transfer once stable on ECMO, I'm supportive of that. But that has to be put into the planning ahead of time before you initiate an ECMO program. John, I hope that's one of your other biggest mistakes people make on your program.
Well, what I was going to say was what I've seen, it's not so much, well, yeah, I mean, it's a mistake as far as not being prepared for the ECMO that you're, for the program is completely got its full talent of people in place 24/7. But what I've seen in my travels here in the last 6-7 weeks with COVID is a sudden surprise. You are now an ECMO program has happened, because what's happened in some very, very large centers that were basically the hub and spoke model, where the hub received all these outside referrals. People would, insert and ship all in the same day. Within a few hours, they put the ECMO on and they were out the door. They had no intention of keeping the ECMO. It's not anything they've ever done. They have an agreement with a very large university center or something like that to accept their ECMOs. Well, all of a sudden, here comes COVID, and that large hub has said, hey, wait a second, you're keeping your ECMOs. We're not taking anymore. We've got way too much going on. Our bed space is limited. Our ECMO capabilities are maxed out. You're going to have to start keeping your ECMOs. And I've been recently to a half a dozen places where they've said this is our first or second ECMO. We normally don't ever do ECMO here. So you had no CCM, critical care medicine, no nurses, no ECMO. Even one place had no perfusionists. Didn't even have them on staff. They didn't know, it wasn't even a heart center. That basically would ship an ECMO the second they got it, and now all of a sudden found themselves suddenly as an ECMO program. So that was an interesting side effect of all this COVID overwhelming of bed space with COVID that I've seen.
Yeah, and I think that was predictable and probably should have been addressed ahead of time. But I'm sure we'll get to that. That's another good talk, actually. But what you just got through saying, and my next concern is, what I'm about to tell you highlights the need for familiarity with the nuances of ECMO, because ECMO is an art form. There are guidelines, there are protocols, there's a lot of data, but there's also a lot of opinion and experience and conflicting data. So I think you really have to know what you're doing. But more importantly, ECMO changes the hemodynamic monitoring model of the patient, depending on whether it's VA or VV, a lot of things happen that make our traditional approach towards assessing a patient's perfusion, their cardiac function, their volume status, a whole bunch of things change, and you have to understand it or you will misinterpret what you're seeing. And it's very important that we discuss these things. So some of my key points are that ECMO perturbs the circulation such that many monitoring methods become invalid. Point of care ultrasound is uniquely valuable, and I can't stress this enough, for monitoring both VV and VA ECMO patients. As ECMO patients are subject to multiple threats to perfusion deficits, intensivist perfusionists should master tools for judging its adequacy. Adequacy of perfusion is extremely important to understand when you're doing ECMO, and you really do need to understand it. You can't be trying to figure it out as you go. You need to understand it. And syndromes especially important to monitor in ECMO patients include LV distension, new onset RV failure, cannula malposition, and extremity ischemia. These are common, very usual problems that occur that you need to be able to identify, recognize, and treat early to avoid there being basically a situation where it is now not recoverable. Uh-oh, what happened? Oh, there. So let's split this up into VA and VV. So we'll do VV first. Sufficient O2 transport to the tissues depends on two determinant factors: O2 content and global perfusion. Threats to perfusion are always present during ECMO. You have RV dysfunction issues, you have hemorrhage, which we've sort of belabored here a little bit, you have hypovolemia, you have vasoplegia, but you can also have, massive third spacing. That's not on there, should be on there. And VV, there is no direct circulatory support. You have to make sure you understand that. However, there's a caveat, and I talked about it in the very first slide. If you have a ischemic heart secondary to hypoxemia, then yes, it will have an indirect effect on circulatory support by making the heart work better. But there's no direct circulatory support with VV ECMO. Very important point that we have to remember. Judging perfusion adequacy, there's fundamental goal during critical illness, it is rather a fundamental goal. Conventional vital signs such as blood pressure, heart rate, urine output, all have very substantial limitations in judging perfusion adequacy, especially when on ECMO. So I want to go over this slide, and this is a very good slide. I covered up the VA section because we're going to look at it in VA as well. So when you look at the venous oxyhemoglobin saturation, it's potentially valid, and it depends on the site of the venous cannula and how much recirculation is present. Note that arteriovenous saturation difference for those with arterial hypoxemia. Pulse oximetry is usually valid in VV. During VA ECMO, however, it's different. So I'm just going to leave anything that's valid or usually valid. I'm going to leave it go. Indicator dilution, which is basically a thermal dilution swan or something like that, lacks validity. May be valid during VV at low blood flow rates. So the issue here is you may be losing some of the flow that you're expecting when you do the thermal dilution. You're going to lose the dilutant itself. So it's going to get captured by the ECMO. So you have to turn the flow way down. NIRS is valid. LVO2 VTI is valid. Pulse contour stroke volume is valid. Again, this is because you basically have normal cardiac function. You have a closed loop taking blood from the venous system, putting it back into the right atrium, and it's a closed loop. Point of care ultrasound is valid, and pulse pressure variation, stroke volume variation to predict fluid response, it lacks validity. The value compromised by small tidal volume, reduced lung compliance, and ventricular dysfunction. So the thing about pulse pressure variation and stroke volume variation is you need to be mechanically ventilated with at least 70 cc's per kilogram in order to be able to have a valid PPV or SVV. So you have to remember that. So when you turn because you have stiff lungs now, you turn that volume all the way down and you're doing your ARDS-NET protocol ventilation with low volumes and all the various other mechanisms that are done. I'm not a ventilation expert or ventilator expert. John might be able to expand on a little bit. It makes PPV and SVV no longer applicable because you need that increase and decrease in intrathoracic pressure to be able to get that to occur. That's why that only really occurs with mechanical ventilation.
But we largely have the vent turned way down, do we not? Is that a big factor here as to why that wouldn't be very accurate?
Yes, because usually you're going to be way down to about 30. You're going to try to get down to 30 cc's or 40 cc's per kilo. So on your vent volume, because when you don't want your peak pressure too high, right? So if your peak pressures are very high, you're going to decrease those volumes, have higher PEEP, and you're going to just sort of be, faster rate, low volumes, try to get the FiO2, the inspired FiO2 down. And so you need a normal mechanical ventilation with a ventilator at a volume of at least 70 cc's per kilo in order for the hypovolemia to be reflected in your pulse pressure or stroke volume variation.
I think, Joe, that this slide's worth leaving up for just a second. I think we should discuss a teeny bit about the first one there, venous oxyhemoglobin saturation.
Yes.
On VV ECMO, what does that mean? What does your number that you're seeing mean? Where are you monitoring it? And what can you derive from that? And where would be the accurate place to monitor your venous oxyhemoglobin saturation? Do you have thoughts about that?
I do have thoughts about that, and I think the only thing you really could do maybe is jugular bulb, but I think anything lower than that, you're really going to be seeing an influence of your return and probably having it affected by your oxygenated blood returning. So I think it will be artificially elevated. And without knowing what it is without ECMO flow, you don't know how much it's being affected. And I think that's why at the end of my slides today, I talk a little bit about the transonic device, which is used for measuring recirculation in an accurate way, which is going to give you, I think, a little more confidence. But I would probably say jugular bulb if you were going to really try to get an SVO2. That's what I would do.
Is there any way to measure an SVO2 on the tip of the PA catheter sitting in the pulmonary artery?
I mean, I'm sure you could probably draw something from it, but that's going to be contaminated with the blood you're pumping back to the right atrium. I mean, if you want a true SVO2.
But the problem with the SVO2 on the ECMO is that it's always got a factor of a mixing component there that we don't know what that is.
Yeah, that's
and
what
the problem with monitoring it in the SVC or right atrium is basically a similar problem.
Yeah.
Is you don't know how much is being modified by the ECMO itself. But what makes it to the pulmonary artery seems to me that now you would get, you're not getting a patient SVO2, that's the problem.
Yes, that's correct.
Yeah,
that's why I said the jugular bulb, because you're higher than your access point of your if you're using a single, the double cannula technique, or even if you're using, or single cannula rather, but even if you're using double cannula, your return is going to be below it. So it would give you at least probably the best opportunity to get that. But I think there's other surrogates that you could use. So, you know, that's you know, my view on that. I don't think, that's why it says potentially
from like
valid.
the left arm or something.
I mean, no, but I don't think that's really going to be an SVO2. That might be maybe a venous saturation from the arm, but I think you need to be, you know, your head is obviously going to use more oxygen than anything else. Your SVO2 there is going to be lower. So that's the one you really, I think, want to measure. That's what I think.
Okay.
So I have, in VA ECMO, on the other hand, I have 3 key concerns. We talked about this already, differential hypoxemia. I worry about that tremendously. LV distension and dilation, I worry about that tremendously. And limb ischemia is a very real problem that has to be addressed, or you're going to start seeing elevated lactates, they're going to get gangrene, and they're going to need an amputation, and it's very ugly. We talked about differential hypoxemia already. It's related to inadequate lung oxygenation and continued LV ejections. The use of NIRS can be very helpful for a continuous monitor to look at cerebral oxygen saturations. And if you are going to measure blood gas, you don't have NIRS and you're going to be measuring blood gases, it is absolutely essential that you measure those blood gases from the right radial artery or right brachial, just out in the right arm somewhere, please. Arterial pressure waveform, well, you're going to have a decrease with VA ECMO in the pulse pressure, and it would likely indicate a decrease in LV stroke volume, but not necessarily. And it is variable based on prior cardiac function, current afterload, LV volume status, and adequate pulse pressure is alone not reassuring in an isolated sense for not having LV distension. So you can have little pulses and go, oh, I feel good about that. You know, we've got some pulses, the heart's emptying. No, the heart could be blowing up and just doing this and get just enough pressure generated to open the aortic valve, depending on how much afterload it has to beat against. So if you're running a sort of a low pressure, then like down around the 50 range, you might actually get an ejection, a little bit of one, and say, I feel comfortable. Doesn't mean anything. That's why I think you got to go back to the bedside transthoracic echo. I think it's very important. And that's what comes up is they call it POCUS. I think you're going to hear a lot more about this, point of care ultrasound. Evaluation of ventricular size and function guides your pharmacologic therapies because you can see, you don't have to wait for them to bring the machine. You don't have to wait for them to get the tech to come do the echo, and it becomes a big event. It should just be there. If you have an ECMO program, you're doing VA ECMO, even VV, but especially VA, you should have an echo available to you whenever you want it to evaluate the ventricular function, because every change you make has a potential effect, and you want to see what that effect was without having to wait until tomorrow. Guide use effectiveness of decompressing technology. So this is what POCUS will do. It helps you decide, do I need an Impella? Should I put a transeptal or a direct LV vent in through the apex? Or if you have done it's a post-cardiotomy and the chest is open already, go ahead and put it in through the right superior pulmonary vein and then through the mitral down into the LV. Extremity perfusion, you need to monitor this regularly. You can use, of course, the NIRS for that too. You can put the NIRS on the extremities, and it does work, gives you some sense that you are perfusing the legs. Of course, you can look at them and you can feel them. If they're relatively warm and they don't look mottled and they're not getting purple or turning into Smurf toes, you know, you're likely doing a good job and you're probably okay. You can try using Doppler, of course, temperature of the foot and appearance. If you're having an issue, you put an SFA distal perfusion cannula in. and you just use a lower lock and put it on the stopcock where the cannula, the opti and the 3/8 tubing is connected, and just put it right in there. We use a little cardioplegia Y line to do ours, and it just works really beautifully. It's very simple to do. So now let's look at VA on that same chart. In VA, now your SpO2 is valid, completely valid. In your VA pulse oximetry, it lacks validity, typically because you don't have enough of a pulse pressure. It just isn't going to sense. And I've seen that happen before where there's no pulse ox, there's no pulse ox. Yeah, but there's no pulse. But they can't be alive. No, they're alive. They have continuous flow. And, you know, just as a caveat to that, the images that we have and videos that we have of reviewing or viewing the microcirculation, it is typically continuous. It's not pulsatile, which is very interesting. The flow through the capillary is one red blood cell at a time, and it's a continuous flow, not a pulsatile flow. So I still haven't figured out why we have a pulse, unless it's just how the heart got designed, because every long-term VAD, every total artificial heart created today is all done off of continuous flow technology, because they don't break like a pulsatile flow does. But I do think it requires some adaptability, because when I measure the microcirculation, when I'm doing hearts and they go on pump with continuous flow short term, I see a tremendous decrease in capillary density and capillary flow. It's amazing at what happens. And then when you see the native circulation restored, you see that return. So short term, I think there really is a big difference in how our physiology works with pulsatile flow and capillary perfusion, microcirculatory perfusion. But I think that our bodies are able to, over time, adapt to it. But I think that is one of the big reasons that duration of bypass, how long you were on pump, is an independent indicator or predictor of mortality. And I think that's the reason for it. We don't have enough time to adapt to this new situation, and we have so many other things happening at the same time as opposed to just one.
Hey Joe, I think that topic right there of pulse versus non-pulse and our physiology could be a very nice 1 or 2 hour webinar for the future. There's research that's been done here at this hospital with regard to that, and long-term patients, bad patients, do adapt, and in fact on the capillary level it seems to be that it's a constant flow, which we both know. However, the research shows that when you have a pulse, it's the energy that's delivered to the physiology that has some type of positive impact on our systems. You know, a pulse, you think to yourself, well, you know, what's the difference if it's pulsatile or constant? Constant actually seems like it even makes a little bit more sense. But when we look at our physiology and we're used to a pulse, there's a tremendous amount of energy that is delivered along with that pulsatile flow. And it's probably way beyond our knowledge and understanding at the moment as to what all that energy is doing and what effect it's having. But there's something there to the energy that's delivered to our system via that pulsatile flow.
Yeah, that's interesting. You know what? That would be a really good topic. But nevertheless, let's go ahead and move on, because I know I'm going to run out of time here. Indicator dilution lacks validity, and it's common sense, right? You shoot your RV is being drained, and you're decompressing it and then pumping it into the femoral system. It says lacks validity, but I can't even believe it would have any validity. NIRS has validity for obvious reasons. Left ventricular outflow tract velocity time is obviously lacks validity, but it may be able to demonstrate the presence of LV ejection even without a measurable pulse on your radial line or distal arterial line catheter. Pulse contour stroke volume obviously lacks validity. POCUS is very valid. Again, I said that several times. I think that needs to become much more common. I would love to have the ability to just do a TTE anytime I wanted to at the bedside with some of these ECMO patients when we're trying to wean, changing flows, making decisions about, is this a volume issue, is this a cannulation issue, is this a decompensation of whatever function we previously had issue, what is going on here? It would be so helpful to have. And then obviously PPV and SVV for fluid response, it lacks validity, and that would be for obvious reasons, I think. Weaning ultrasound, very, very important to assess LV function and makes the weaning process so much more effective. But it does require a cessation of support in order for it to be completely valid. Is this patient going to be able to make it off of ECMO? There's other ways to do it too, and using microcirculatory measurements, viewer, it's called dark field side stream imaging, is extremely helpful for this as well. But I think echo is maybe a little bit easier to do. I'm not sure, because that other thing is pretty easy too. But you need to stop the pump at some point, and you really need to consider your anticoagulation status at that point, because ceasing flow, if you are inadequately anticoagulated, is obviously going to have a catastrophic event should you have to go back on flow. So it has to be brief, but you need to make sure that it can be longer the more anticoagulated you are. I would also put a recirc in. This is the transonic device I talked about, and this device does three things. It measures flow on a continuous basis. It measures the amount of recirculation in your VV ECMO patients or cannulation strategy, and it simultaneously measures the intra-oxygenator blood volume. So if you know your oxygenator has a blood volume of 220 cc's, that's what the manufacturer, MFU, says, and you know that to be true, and you start your ECMO immediately and run a baseline, and it comes back 220 cc's, and then you're out in the Wild West on the East Coast where John is in Florida, and you're doing these ECMOs without any anticoagulation, and you wait 4, 5, 6 days, or do it the next day, or do it every day. I would say do it at least once a day would be appropriate if you have the device. And you measure your intra-oxygenator blood volume, and it goes from 220 to 200 to 180 to 150. Well, in 4-day period of time, well, that volume is not being occupied by popcorn. It's being occupied, the only thing it could be is clot. And so you can know when your oxygenator is starting to clot. And it's very interesting, several papers out there that you can lose almost 70% of your oxygenator volume before you see an appreciable change in your delta P. And most people, at least I've abandoned, and I think most people I know have abandoned, measuring pre and post membrane pressures. We don't measure them anymore. Do you do that? Do you measure them, John? I don't measure them.
Yeah, because you get them automatically on the CardioHelp. It gives
Oh, that's right.
automatically.
You use CardioHelp. We don't use the CardioHelp.
So are you using this device to tell you the status of your oxygenator? How are you keeping track of that?
Yes. So this device is just fantastic. It's very portable. One can cover any number of patients, any number of hospitals. You just take it, you hook it up, you put the patient information in, it stores it, so you don't have to always do that. You do an injection of 20 cc's of saline. It sort of has instructions how to do it. It has 2 probes, one on the axis, one on the return, And with that one injection, now it's going to give you flow immediately, so it's an ultrasonic flow meter, but as soon as you give that injection, it takes about 60 seconds, and it does its calculations, and it will give you your percentage of recirculation if you're VV, not if you're VA, obviously. If you're VV, gives you percent of recirculation, and it gives you your intra-oxygenator blood volume in about 60 seconds. So you know what your effective ECMO flow is, because it gives you that number as well. So if you're flowing 5 liters and you have 20% recirculation, the math is simple. It's going to be 4 liters of effective ECMO flow. And but it's an excellent tool, because I've seen recirculation of 15%. I've seen recirculation of 50%. And that one that was 50%, with cannula manipulation, we were able to significantly improve the patient's oxygenation arterially, and made for a much better opportunity for survival for that particular patient, because we were really struggling and we couldn't understand what the issue was. But it was cannulation placement.
Joe, how often are you seeing with that device, probably almost on a daily basis, you're able to see your oxygenator volumes dropping, which means it's being replaced with clot inside the oxygenator. That's what it's telling you. And then about the recirculation aspect of it, what has been your experience with how different from patient to patient, and how many instances have you seen where maybe you've done something to improve your recirculation?
Yeah, so I would say that the most of the time, anything that is 20% or less of recirculation, we accept. You know, the enemy of good is better, right? Anything higher, like in the 25, 30%, we will try to make a few minor little adjustments, but it's what's so important about this is you want to do this while the cannula is being placed. Everybody's there. Nothing has been sutured down. So you make your adjustment at the time of insertion. What I have experienced is that once you have gotten an optimal position and they secure it well, nothing changes. We've flipped patients over with no prone bed, literally taken the patient and turned them prone and turned them back over the course of several days with no prone bed, nothing automated at all about it, and the recirculation continues to stay where it is within an acceptable range. It might be 15, 17, 20, 18, something like that, but it doesn't go 15 to 30. So we haven't experienced that at all. As far as the oxygenator volume is concerned, I have seen, we're very careful about our anticoagulation protocol. We don't do no heparin, but we have had a very good experience. In fact, we haven't had any case where the oxygenator blood volume was reduced by more than maybe 15% at best over the course of 10 days, 10 to 14 days. What happens is the fibers just wet out before we have that occur. But our oxygenated blood volume has stayed very stable. And so, I think I would really like for you to do it with your patients that you are not anticoagulated, because I think it would be, if you had virtually no other change, I think that would be so incredibly powerful and valid that it would help so many of everybody. It would help me. If I had that data, I would be like, okay, this is conclusive in my view.
Yeah, that would be interesting. What about in terms of, have you experimented with the device and taking a patient and increasing and decreasing the flow to see where your optimal flow is and your minimal mixing is? Have you experimented with that?
Yes, absolutely. And I have been able to demonstrate that coming down on the flow has decreased recirculation and increased effective ECMO flow simply by reducing the RPMs. And I had mentioned that in the very beginning, but I knew I had this information moving forward. But thank you for that question, because I really did want to make that point, and it's a very good point. Okay, so last thing, John, is microcirculation. You and I have discussed this before. This is what the device looks like. I happen to have one. It is from Microvision Scan in Amsterdam. You can find them online. It is a very interesting, unique device. And let me show you what you see. And this is a good example. If you look at A, which is relatively normal, same patient B, you have a very deranged microcirculation. I don't have it on video, but you can find these videos if you just go on YouTube and type in dark field side stream imaging or DFSFI. You will find these videos of microcirculation that these devices, and this particular one is a very easy to use, very nice device. And it is measuring, what you're seeing there is down in the, 7 to 10 micron range, and seeing actual capillary density and watching them disappear during various moments, or watching hyperemic flow through, like in sepsis, through the capillaries, seeing capillary bridging. You can see all of these things. The bigger vessels that you see are arterioles and venules, but the capillaries are very, very small. And this sees a lot, and it's a very unique tool. I really enjoy it. And here you can see what happens from 0 minutes to 10 minutes before hypoxia, during hypoxia, and after hypoxia. So if you look at the left, you see the larger arterioles and venules, but you also see the very small little capillaries, okay, the things that I was saying down around 7, 10 microns. And then at 3 minutes, you can still see them, okay, that's before hypoxemia. During hypoxemia, look, and you can see them disappearing. And then after hypoxemia, all the way out to 10 minutes, look at the difference in those really small vessels, the ones where gas exchange is actually going to occur. And it's amazing to see this happen. I have watched this happen by myself. And I would love to bring this out to your place too and show this to you, because I think it is just such an incredibly unique tool that is so underappreciated and has such incredibly valuable information. For ECMO, in fact, there's great papers out there talking about the use of this for weaning off of bypass. So using this as a metric to determine whether or not the patient is going to successfully wean. You go from 100% to 50% VA ECMO flow, and if your microcirculation stays intact, this particular article, and I can't remember the name of it right now, I'll have to get that reference if anybody wants it, or you can try to find it yourself online. I'm sure it's there. You have a statistically significant chance, improved chance, of that patient being successfully weaned from VA ECMO. Now, it's not the only thing you look at, but I think it should be one of the things, because if you see the microcirculation just drop off and go down, going from 100 to 50%, they say in the paper that patient is likely not coming off ECMO at that point. But if you have it maintained, then that patient is likely going to come off ECMO if you continue with the weaning process. And I think it's a very powerful article, and I recommend people find it. I'm going to try to reference it in the YouTube. So I have a little bit of discussion time, John. I know we're running over. We belabored a lot of points. Any final thoughts maybe you could give us about all of this and what your thoughts are about these technologies? Because hemodynamic monitoring is not just blood pressure. It's not just urine output. It's not just laboratories and the routine labs that we do and all of that. It's more than that, right? And I think we need to take all of these things into consideration. We need to know whether we're developing clot in our oxygen. We need to know what our recirculation is on VV ECMO. We need to know what our microcirculation is doing, because you can have all the macro circulatory flow you want. If you don't have microcirculatory flow, the outcome is predictable.
Yeah, and I think a lot of our measurements are sort of gross macrovascular measurements. You know what I mean? We don't have a whole lot of microvascular measurements. In fact, I don't know if we have really any. One thing I like, we didn't talk a lot about the NIRS in this particular lecture, but we've talked about them before, especially if you put them on different limbs, compare different limbs and the head, you'll see regional differences. I mean, that may be about the closest thing we have, which is not very good, to kind of measuring near our capillary perfusion. And even that, as we know, because of the depth of how that measures, is actually a very poor indicator more than anything. But, you know, the next frontier for what we do should be microcirculation.
I think so, too.
Because this is an area that we just never delved very much into, not much as perfusionists anyway. And it ought to really be, you know, this is where the rubber meets the road. At the capillary level is where gas exchange occurs. We talk about
gas exchange, nutrient exchange, everything exchanges.
Right, and you know, we're looking at SpO2s. Well, that's not very accurate. Our cardiac outputs on VV ECMO, no matter what you use, not very accurate. You know, you're trying to draw from the right radial, and you're hoping that that's giving you, you know, what you need to know that's going to the brain. So, you know, but if we knew exactly on the capillary level in the brain and in the tissues what is really happening, I think there's a whole frontier of knowledge that we could expand ourselves and really learn, you know. And you know, we have another inference is lactates. We infer a lot from lactates, and we've discovered that there's times when lactates are low, but tissue perfusion is poor, and we've actually seen the opposite as well. It's not 100% of an indicator, although we tend to think it is.
And they lag. They lag.
It's a big lag. That's one big
and they
problem,
can happen for a variety of reasons, you know, at all kinds of, and it can be masked. You have the patient on CRRT, you may not see and I didn't even discuss that, but if you have a patient on CRRT and you're doing high replacement volume, high effluent volume, then you will mask that lactate level because it's going to clear it very effectively, very quickly.
Lactate. Yeah, and the other thing too is, you know, with all the huge concerns and all the things we talk about with acute kidney injury, wouldn't it be good to know if we could monitor on the nephron and the capillary level of the kidney, the perfusion that we're actually doing with non-pulsatile flow on perfusion, with ECMO and other things? Maybe there's a whole ton to be learned there about what's really going on with AKI, as opposed to all the theories and inferences about all the many, many things that are accused of contributing to AKI. You know, I think there's a lot to be learned there on the microcirculation, just in all kinds of areas.
I think so too. I think you're 100% right. You hit the nail on the head. So, okay, so in deference to John, your time, and to everyone else out there that has stayed with us, I think we were supposed to end at 10:20. So I think we're actually really, no, 10:15. So we just went a little bit over, but it makes up for yesterday when we were a little bit under. So hopefully the board will be happy with that. Every once in a while, I kind of sort of make one go over a little bit. Monday, August 10th, 9 a.m., same place. We're going to have Tammy Sparacino's Journal Club. We're going to be tackling the topic of predictors of heparin resistance before cardiovascular operations in adults. And there's going to be the second installment of our M&M, our Morbidity Mortality Conference, Learning from Others' Mistakes. And the case that I'm going to discuss is going to be very interesting indeed. And, you know, I'm hopeful that by the time I finish this M&M series, that everybody out there gets themselves a really good prescription for Zoloft, because there's a lot of bad things that happen in heart surgery that perfusion is related to, and we never, ever hear about it. And I think it's so important that we reveal this stuff because, you know, the old saying, John, there's those that have and there's those that will.
Correct, by Charlie Reed.
That's right. That's exactly right. Exactly right. Okay. Good day, everyone. Thank you, John, once again. I love you. I appreciate you so very much. Did you see that comment that we got from down under?
No, I'm not watching the comment board at all.
Okay, I got to tell you the comment. I love, this is from our Australian friend. I love the conflicting points of view between you and John. Makes for a great conversation. So I thought that was a great comment. I really enjoyed that one. Okay, everybody, we'll see you August 10th. Thank you. Be safe. Stay safe. Have a great rest of your weekend coming up, and we'll see you later. Talk to you. Bye.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP Venous Cannula and the EasyFlow Duo. For arterial, direct, and venous femoral cannulation, the EasyFlow aortic cannula and the wrap are available. For venous femoral access, the LivaNova wrap cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of wrap improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo Cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.